low, meaning acidic, and HCO3 is low, remember it's a base, then the disorder is metabolic acidosis. If the pH is high, meaning alkaline, and PCO2 is low, it's an acid, the disorder is respiratory alkalosis. And if the pH is high, meaning alkaline, and the HCO3 is high, it's a base, the disorder is metabolic alkalosis. Would an elevated PCO2 cause an elevated pH? No, because an elevated pH indicates alkalemia, and an elevated PCO2 indicates retention of acid. The third step in interpreting the results is checking for compensation. Compensatory mechanisms help return the body to a state of equilibrium. Look at the buffering system for the primary problem, either PaCO2 or HCO3. The buffers will shift in the same direction if there is compensation. The disorder might be partially compensated, or uncompensated. Example: pH equals 7.15. Step 1. Acid. PCO2 equals 68 millimeters of mercury. Step 2. Respiratory. HCO3 equals 22 milliequivalents per liter. Step 3. Uncompensated. Note: HCO3 is not elevated. Therefore, it is uncompensated respiratory acidosis. The next day, we draw another set of ABGs. The pH is 7.25, so it's acidic. PCO2 is 68 millimeters of mercury, so it's respiratory. And HCO3 is 30 milliequivalents per liter, which indicates compensation. But the pH has not returned to normal, so we call it respiratory acidosis with partial compensation. The following day, the pH is 7.36, so it's normal. PaCO2 is 60 millimeters of mercury, so it's respiratory. HCO3 is 39. HCO3 remains high to buffer the increased PaCO2, but the pH has returned to normal. So now we can say that it is respiratory acidosis with total compensation. Now here's the situation. An infant is brought to the emergency department with a history of poor feeding and diarrhea for 4 days. Her pH is 7.33. Her PCO2 is 29 millimeters of mercury, and HCO3 is 17 milliequivalents per liter. During Step 1, you determine that the pH is acidic. Step 2, you look at the HCO3 and see that it's low, so it's metabolic. Step 3, you see that the buffers are moving in the same direction. PCO2 and HCO3 are both low, so it's compensated metabolic acidosis. What are your nursing responsibilities related to arterial blood gases? Watch the client for signs and symptoms of acid-base disturbances. You'll also monitor fluids and electrolytes and administer oxygen as necessary. A client in active labor is anxious and tachypnic, has deep respirations, and reports numbness in her extremities. Which acid-base abnormality is she at risk for? It would be respiratory alkalosis because she's blowing off CO2. What are your nursing interventions? You'll provide a calm environment, help the client relax, have her breathe into a paper bag to retain some CO2, and provide pain medication. Remind her of the breathing techniques she learned in childbirth preparation classes. You've just received a client from the post-anesthesia care unit following a pneumonectomy. His respirations are 11 per minute and shallow. Which acid-base abnormality is a client at risk for? It would be respiratory acidosis, because he's retaining CO2 as a result of shallow respirations. What are your nursing interventions? Have the client cough and deep breathe. If he is too sedated, check to see how much narcotic analgesia he's had. The opioid antagonist naloxone, or Narcan, might be indicated. You have a 3-month-old client who has gastroenteritis with frequent diarrhea. Which acid-base imbalance is the client at risk for? Metabolic acidosis, because she is losing bicarb in watery stools. The nursing interventions are to treat the underlying problems of diarrhea and gastroenteritis, usually with NPO status and IV rehydration. In extreme cases, we might administer sodium bicarbonate. You'll have to support the client's respiratory system so that it can assist in buffering the acidosis. Your client has had gastric surgery with prolonged NG tube suction. What acid-base balance is he at risk for? Metabolic alkalosis, because he is losing acid in his stomach contents. What are the nursing interventions? Make sure suction is intermittent. Try withholding suction for longer periods of time if necessary. Replace electrolytes. I hope you found that ABG review helpful. Remember, practice makes perfect when it comes to interpreting ABGs. Now, let's see. What areas haven't we covered? How about respiratory therapy? As you know, oxygen therapy is critical for clients who have respiratory disorders. Oxygen is administered to augment cellular perfusion and to relieve hypoxia. Clients who might need supplemental oxygen include those who have hypoxia, hypoxemia, severe bleeding, trauma, or respiratory diseases, or are recovering from general anesthesia. What signs and symptoms indicate a need for oxygen therapy? Restlessness, respiratory distress, cyanosis, rapid shallow breathing, confusion, stupor, coma, tachycardia, use of accessory muscles, wheezing, and lung crackles. You'll assess oxygen status by monitoring ABGs and pulse oximetry readings, and you'll prepare the client for other diagnostic tests, such as chest X-ray and pulmonary function tests. Generally, the respiratory therapist will set up the oxygen delivery system the physician prescribes. Oxygen can be delivered through a number of different devices. They include face mask, nasal cannula, tent or hood, and ventilator. Respiratory therapists and nurses work closely together to monitor respiratory status. Often, it is the nurse who will explain the purpose of the therapy to the client and family, position the client to enhance breathing, teach the client techniques to remote breathing, and encourage deep breathing and incentive spirometer. It is also very important for the nurse to monitor the effectiveness of oxygen therapy. Oxygen therapy, like any medication, can cause complications. What complications might